Okay. All right, so thank you all for joining us. My name is Sumaira. I am the founder and executive director of the Sumaira Foundation. I started this 7 years ago, just 2 months after I myself got diagnosed with neuromyelitis optica. The foundation is focused on raising global awareness of both NMO and MOG, fundraising to support research to hopefully one day find a cure, or at the very least improve our quality of lives. We're passionate about building communities of support for patients and caregivers, just like tonight. And we've actually just added a fourth pillar to our organization, which is advocacy. You know, we believe that the way we're going to make some real change for patients is by raising our voice to decision makers and sharing our stories, elevating our voices to hopefully help inform legislations that will support not just NMO patients, but patients in general, specifically rare disease patients. So that's a little bit about me and the foundation. Typically at this hour on Thursdays, we have something called the Human Collective Project, which is an initiative that we started in the midst of COVID. So I believe in July or August last year. It was very clear to me and the rest of the ambassadors that so many of us, you know, we were all stuck at home, craving connectivity, especially with each other, and finding a safe space where you can really talk about things that only other patients and perhaps caregivers understand. So it's been wildly successful, so much so that we promoted one of our ambassadors from Arizona, Ms. Dominica Zinger, who's on the call, to the program manager. And things are happening on that front. It's growing. We're developing a human collective project for our friends in Europe, our friends in Asia, our male patients, our youth patients. So lots to come on that. So allow me to turn it over to our friends from Alexion, patient education managers Mike Law and Bill Busk, as well as Nicole McLeod, who is our TSF ambassador of New York, and Dominica Zinger, who will be presenting to you all about the differences between NMO and MS. Obviously a topic that we all, you know, can resonate with. And will be opportunity for questions and answers. That portion will not be recorded. And if you are too shy to ask them via video, please feel free to populate your questions in the chat, and Bill, Mike, Nikki, or Dominica will answer them accordingly. Before I hop off, I just wanted to say thank you so much for coming. We know everyone's time is super valuable. And more importantly, thank you for being a part of this conversation. The more conversations we have as a patient community, the more we'll achieve. So thanks. I'm around. I'm just shutting my camera off. And with that, Mike, I will make you a host.
Thank you. And I'll start sharing my screen here.
Great. And I am going to mute everybody until it's time for the Q&A, just so that there are no.
Whoops.
Sumaira, can you leave Nikki and myself unmuted because we're supposed to interject?
Yeah. Everyone else.
Well, hello, everyone. Can everybody see that? And hear me all right? Again, my name is Michael. And first of all, Sumaira, thank you for having us. I'm the patient education manager for Alexion and OneSource, and I'm here with my colleague, Bill Busk, who is the patient education manager in the Northeast. And we have a very unique role here with OneSource and the patient education managers. There's actually 10 of us across the country, and we play a unique role in terms of educating patients, working with organizations like yours, as well as infusion in services. And it's a really good opportunity for us to meet with individuals one-on-one So with that, I just need to make a disclaimer, and that is that the opinions and experience expressed are those of people sharing, not necessarily that of Alexion. So now that we got that done, let's move on and get to the topic at hand, which is MS or NMOSD.
Hey, Mike, would you mind making the slides bigger?
Oh yeah, absolutely. They're not
Going
big
into
enough.
presentation? Yeah,
Put them
perfect.
in presentation mode. And the other thing is just keep an eye out for the waiting room because there might be some people trickling in a little later.
Oh, that's weird because I am in presentation mode. I don't know what's going on.
Oh, rats. Do you want me to give it a shot?
Yeah, if you don't mind, Bill, I don't know what's going on with my screen here. I
Yeah,
apologize.
not at all. Why don't you?
Yep, I'll
why don't
stop
you-
sharing.
Great.
I don't know what's going on. Sorry, everybody.
That's okay. Mike, do you want to make Bill the host now?
Sure.
Yep.
Mike, remember, it's not you, it's the technology. You had nothing to do with it.
Exactly.
All right. So how do I make Bill the host again?
So you want to go to the three buttons at the top, the upper right-hand corner of Bill's box, and then
Yep.
click that, and it should say make host.
You want to watch this?
There you go. Perfect.
All right, I am
All
the
you,
host
Bill.
now. All right, rock and roll. So let's share screen.
NMO versus MS, what the differences are.
All right.
It's a discussion.
Okay.
Okay. So, are you in a Zoom call? No, it's a meeting with everyone. Who? Just random people.
Are you on mute?
All right, how's that?
Stephanie,
Full
you might
screen?
want to
That's
mute
perfect,
yourself.
Bill. Thank you.
Awesome. Okay.
Sorry.
No worries.
No worries. No worries. Mike, so I believe you were just introducing the slide,
Yep.
MS or NMOSD, and we were
Well,
moving
the
on
next
to,
one. Yep.
there we go.
So again, welcome to today's talk. Again, please don't take any photos or pictures during the presentation. If you could also silence your cell phones as well as mute your computer, that would be great. I do apologize in advance if you hear my dogs barking. I apologize. And remember that the information in this presentation is intended to be educational for patients being tested for NMOSD, people diagnosed with MS whose symptoms are still uncontrolled, and caregivers. It does not replace a doctor's independent medical judgment or clinical diagnosis. It's important that you speak with your doctor about your diagnosis journey, including planned testing, test results, symptoms, and responses to past and current management options. Next one. So today's topic, we're going to discuss three areas, and that is the similarities and differences between MS and NMOSD. What are the right diagnosis matters, and tests to help confirm or rule out NMOSD. Now I'll turn it over to Bill and talk about the similarities and differences between MS and NMOSD.
Awesome. Thanks, Mike. So the first place we're going to talk about is kind of how MS and NMOSD are similar, how they have many of those same clinical features. They're both chronic autoimmune diseases that cause damage to the central nervous system. And let's break that down a little bit. So autoimmune means that your immune system is mistakenly attacking your own body. In the case of NMOSD, those are very specific antibodies that are attacking very specific proteins in your central nervous system. MS is there isn't that very clear diagnostic marker just yet, but they both are chronic autoimmune diseases. They both affect the central nervous system, including the brain, spinal cord, and optic nerves. They can both lead to vision loss, mobility issues, potentially other forms of disability. And I think we all can agree that both of these diseases have huge impacts on the day-to-day lives of patients, as well as their loved ones, their families, and their caregivers. So let's talk a little bit of about the history. So NMO, like we said, is this rare autoimmune disease it actually used to be considered a type of MS. Once upon a time, it was called Devick's disease, that it had been originally sort of researched and discovered by this gentleman named Devick. But now it's diagnosed and treated as a separate disease. It's also characterized by unpredictable relapses that can result in various disabilities, including blindness or paralysis, and some relapses that can even, unfortunately, lead to premature death. Recent research has uncovered key features that set NMOSD apart from MS. And some of the important ways that we're going to talk about that they differ is in the types of people that MS and NMOSD affect, as well as the symptoms experienced, the nature of relapses, and the underlying cause of damage. And just to note, the terms attack and relapse are used interchangeably in this presentation. Letting another person into the room. Very excited to have you. So again, attack and relapse, we're going to use those interchangeably, but we're really talking about the same thing. Now, I'd actually like to take a moment because, you know, Nicole and I have met before, we've been working together, and she mentioned something to me that was so impactful. She had said to me once that when she was first diagnosed, she was told that she had the worst kind of MS. And so I was wondering, Nicole, if you wouldn't mind kind of speaking to that.
Yeah, when I was diagnosed in 2018, and mind you, this is after they had figured out that this was not MS, it was separate. The attending neurologist at the hospital said that it was basically MS's like twin sister, evil twin sister, or evil twin cousin, and not to Google anything. And within an hour of them leaving the room, that was exactly what I did. So, yeah.
I can imagine that was just a really scary thing to hear, and feeling probably pretty alone when that happened.
Especially because I was alone when I got the news, and I had never heard the term neuromyelitis optica. I'm like, what the heck is that?
Yeah.
So,
well,
yeah.
Hopefully tonight we can shed a little more light on it. So just a kind of a quick call to action, you know, NMOSD is rare and some doctors may not be familiar with it, kind of similar to Nicole's experience. So if you already have a diagnosis of MS, don't be afraid to ask if there are other diseases with similar symptoms, such as NMOSD, and ask if they've been ruled out. So let's look at the numbers. I'm just going to reveal the whole slide because I think it's pretty cool. There we go. So let's kind of start with just, you know, how frequent it happens. So NMOSD is actually much less common than multiple sclerosis. Out of every 100,000 people in the United States, 310 would potentially have a diagnosis of multiple sclerosis, whereas really only 1 to 10 people would have a diagnosis of NMOSD. So it's much less frequent. The age of onset is actually different too. So it's older in NMOSD, with the average age being 39 years old versus 29 years in MS. Just like MS, women do make up a larger portion of those affected, but it's much more frequent in women. So 9 out of 10 people with NMOSD are women, whereas 2 out of 3 people with MS would be women. And then finally, there's racial disparity as well. So NMOSD tends to be more common in those with Asian or African, those from Asian or African descent, whereas MS is much more common among Caucasian or white people. Now, we're going to break it apart now by symptoms. Though some symptoms of MS and NMOSD are shared, such as vision changes, spasms, limb weakness, numbness, as well as pain, paralysis, fatigue, and potentially that loss of bowel or bladder function. The symptoms that are only associated with NMOSD are blindness, hiccups, nausea, and vomiting. And this kind of brings me back to sort of another event in Nicole's journey that she had told me about. Nicole, do you want to shed a little light on that for us?
Yeah, if you can see this slide here, the symptoms only associated with NMOSD, the blindness, hiccups, nausea, and vomiting. I didn't have blindness, but I did have vision loss, significant vision loss in my right eye. I had hiccups, I had nausea, and I had vomiting. The vomiting lasts 6 weeks before they figured out that it was NMO. It was nonstop. I was turned away from the hospital 3 different times and then finally admitted. And that's when they figured out that it was NMO and not MS. So, yeah.
And when you had presented with those symptoms, were they thinking NMOSD or what were they thinking?
They were thinking I had the flu
Chicken
and
with
giving me
legs.
fluids and turning me around. Yeah. Anti-nausea and flu.
And that must
Frustration.
have been just
Yep.
so frustrating.
Exactly. Yep.
So just to keep things moving, let's kind of come to our sort of next call to action. It's so crucial to receive that right diagnosis so that your doctor can manage your condition properly. You know, perfect example, Nicole was reporting that she was having these symptoms, but nobody was putting the pieces together yet. So it's important to ask your physician if any of your symptoms could potentially be signaling NMOSD. Now, we're kind of at a part in our presentation where we're going to introduce, a scenario. Sarah is a 40-year-old paralegal, wife, and mom, and we're going to follow her path to diagnosis. So she's kind of just like you and I. She's got a family, she's going on with her life. And then out of nowhere, she wakes up one day with blurred vision and intense pain in her left eye. At the hospital, routine lab work comes back as normal, right? So that's just your regular run-of-the-mill blood work, not testing for NMOSD at this point. A brain MRI shows inflammation to that left optic nerve. She's diagnosed with optic neuritis and treated at the hospital with IV steroids. And so at discharge, Sarah's prescribed an oral steroid and instructed to follow up with a community neurologist. And she's kind of at a crossroads now. She can either start taking the oral steroid, or she can pause and ask her doctor if there's other possible diagnoses or other possible causes for her optic neuritis that have been ruled out. And I think we can kind of look at this and say, with hindsight, what choice we think she should make. But in this instance, Sarah starts taking the oral steroid. She trusts her physician, she moves forward, and that's the path that she's taken. Now, I'm kind of curious if anybody would like to share if this story resonates. Is this something that anybody has experienced before? I see Stephanie raising her hand. Oh, do we need to unmute you?
Okay. It's not me. Actually, I have a 16-year-old son who in May got sick, had vertigo, had slurred speech, and actually woke up one day and his right eye was totally in. He saw double, he couldn't see anything. And after 4 trips to the ER, I'm from Indiana, we ended up in Chicago at Comer's Children's Hospital. And at first they thought he had MS. He had numbness in his arms. We went to the doctor, they thought he had carpal tunnel, put him in a brace. It was like weeks of episodes just happening. And they thought he had MS, so we went to the hospital. They started him on steroids. Then they thought he had NMO, and blood work was sent away, and the antibodies came back negative with that. And now they're putting him in the MS category again. So, and the steroid, and he had another instance because he has lesions on his optic nerve, on his medulla, in the back of his neck. And we were back in the hospital in September and now on 8 weeks of steroids. So, we did the steroids and they helped him with his symptoms and being good, but we're kind of in the middle now, like not knowing where he's at and what he's doing. So this is so interesting to me and wonderful, but yeah, his steroids really helped him. Like in the hospital with his vision right away, within 24 hours, his eyes started going back and it was great.
Wow.
But if we wouldn't have had the weeks before prior, like she did, I probably would have just done the steroids and went home. and not thought about it. But luckily we got to a good hospital that like started digging right away with him, like something's not right. The MRI, you know, what they saw was not right. But we're still kind of in limbo with what he was. And with being 16 too, that's kind of a, like, he's really young, but
Yeah.
he has all these symptoms of NMO and MS, and they can't.
Right. And Stephanie, thank you so much for sharing, because it perfectly illustrates this point of like, we don't always know what the right choice is. We make the best choice we can with the information that we have. And that's really the purpose of this talk, is to kind of talk about the pieces of information that you should be asking about. And it sounds like you're asking all the right questions. So again, thank you for sharing. Now, I'm going to hand it over to Mike, who's going to talk to us a little bit now about why the right diagnosis matters.
Thanks, Bill. So again, why the right diagnosis matters. People with NMOSD may be initially misdiagnosed with MS. 43% of the patients with NMOSD in one study were initially misdiagnosed with MS. The wrong diagnosis of MS became less common after AQP4 antibody tests became commercially available in 2005. When you look at 20% versus 54% in one study. The reasons why doctors may misdiagnose NMOSD with patients with MS is that NMOSD is a rare disease, and that they may not be familiar with certain tests used to help the diagnosis. And really an important part is that NMOSD and MS can overlap in so many different symptoms. Next one, Bill.
Oh, trigger happy.
It's all good. You can proactively discuss NMOSD with your doctor. Ask if NMOSD has been considered as a possible diagnosis and whether you should be tested for it. So again, a misdiagnosis of MS may have a potential devastating consequence. Just one NMOSD relapse can cause serious permanent damage. And NMOSD, one of the main goals for managing this condition is reducing the risk of relapses. And it's possible when you have the right diagnosis and management plan in place. How NMOSD relapse differ from MS? And I apologize for this slide because there is some red in there. And I know that's difficult for some patients to see, so I'm just going to read it. Symptoms are more likely to be severe. Disability is directly tied to attacks. Consequences may be permanent, and disability can be cumulative. When diagnosing NMOSD, time is of the essence. NMOSD relapses are unpredictable. Relapses can occur as soon as a few weeks or months after diagnosis or onset. Before recent advances in NMOSD management, the vast majority of people with NMOSD experience relapses. And 55% of patients in one study relapse within 1 year from diagnosis, and 90% of the patients relapse within 5 years from diagnosis. So an early and accurate diagnosis can make all the difference. The sooner NMOSD is diagnosed, the sooner your doctor can properly treat your condition. MS and NMOSD are managed differently. Some approaches to managing MS can make NMOSD symptoms worse. And effectively managing NMOSD can help reduce the risk of relapses. And this is a quote from a known patient, or a patient. I'd suspect something wasn't right with my MS diagnosis for some time, but getting confirmation that my gut feeling was right all along was still hard to believe. I was told that I'm lucky to be alive and as able-bodied as I still am today. So I'd just like to throw this out there. I know we had some good feedback from Stephanie, but I think it's so important, and maybe Nicole, you can share some light on this, but how important it is to challenge your physicians in the process. Does anybody have any thoughts?
I can go ahead. So for me, before 2018, when I was diagnosed with NMO, I was suspected to have MS for 2 years. And before that, there was a couple of other things going on with some optic neuritis and stuff like that. I literally didn't hit all of the clinical manifestations to reach that diagnosis for MS. And honestly, looking back, knowing that the MS meds make NMO worse, I think that was kind of a blessing in disguise. But yeah, definitely challenge if it doesn't feel right in your gut, because I've been through 4 or 5 different neurologists until I felt comfortable and had the right team.
So really the key is to find your champion, right, Nicole? Find your
Absolutely. Yeah.
Thanks for sharing. I
agree with Nicole on that. Like, they're the expert, but you're the expert on your body. Whether, you know, and even like as a parent or a caregiver, you're even possibly more the expert on your child's body. So keep, you know, if it doesn't feel right, keep at it. Keep at it until you find the answers and you start feeling like you're heard and that they understand you.
It's a very good point, Tamanika. Thank you. So don't wait until you experience a relapse to discuss NMOSD. Talk to your doctor today about testing for NMOSD. So here we are, part 2 with Sarah's diagnosis. Again, Sarah has adjusted her lifestyle and work habits to cope with the visual impairment in one eye. She's had another attack. 3 months later, Sarah's experienced a sudden loss in vision in both eyes now, and she's at the hospital. Sarah's vision doesn't improve with IV steroid treatment. Routine lab work comes back as normal. A brain MRI shows damage to both optic nerve and a portion of the spinal cord. Blood antibody test comes back negative, and the doctor diagnosed the patient with MS. Sarah receives plasma exchange therapy at the hospital, and at discharge, Sarah is prescribed oral steroids and oral medication for MS. So here she is at the crossroads. What do you think she does? Does she start with the oral medication for MS, or does her husband Jaden ask the doctor what type of antibody test was ordered? Let's see what that answer is. She starts with the oral medication for MS. Next one. So now let's take a look at some of the tests, and I'll turn it over to Bill to confirm or rule out NMOSD.
Awesome. Thanks, Mike.
You bet.
I was very selfish in asking to present this part because I just get so excited about the science.
We both fight over this part.
We do. I mean, the science is just so interesting and intriguing. So we're going to kind of dig into the nitty gritty of how NMOSD is diagnosed. Now, for most patients with NMOSD, your body wrongly makes antibodies against your own AQP4. AQP4 is an abbreviation of aquaporin 4. These are water channel proteins that help control the water moving into and out of your central nervous system. So those antibodies trigger a part of your immune system called complement. And then once complement is activated by these antibodies, it can cause damage and inflammation to the central nervous system. And that's when we start seeing those NMOSD symptoms. Something that's so important to know and to understand is that those anti-AQP4 antibodies are frequently found in NMOSD, but they have not been found in patients with MS. And actually, 73% of patients with NMOSD, when tested, have the anti-AQP4 antibodies. Now, that's an interesting statistic to throw out there because I trust the science. I know the science is real, but in speaking to a lot of patients, I know that sometimes, patients are diagnosed with NMOSD without having those anti-AQP4 antibodies. So a simple blood test for anti-AQP4 antibodies is a crucial part of an accurate NMOSD diagnosis. And so there are other parts of that diagnostic criteria that physicians look at as well. So a physician would also look at a patient's medical history, their physical exam, and a variety of specialized tests. Some of those tests may include a spinal tap with examination of CSF or cerebrospinal fluid. magnetic resonance imaging, MRIs, or computed tomography, CT scans. Now, one method of blood antibody testing provides more reliable results. Now, this is such an important slide because there are actually two types of tests that are available that are used to analyze blood for those anti-AQP4 antibodies. There's the cell-based assay, and then there's also the ELISA testing. Cell-based assay is better at detecting those anti-AQP4 antibodies when they're present. ELISA testing is actually up to 15 times more likely to give a false negative result than a cell-based assay. Now, I think in planning for this presentation, we planned on doing polls, but I don't know if that's possible tonight. So I just want to throw it out to the group, maybe a show of hands. Who knew that there were two different types of tests for the anti-AQP4 antibody? All right, Stephanie is our star pupil.
It's all fresh in my mind right now.
Yeah, okay.
Thanks for sharing, Stephanie.
And if anybody else would like to pop in and share their thoughts or questions, we can do questions and answers at the end, but if you'd like to share your thoughts, that would be great. All right, so we're going to keep moving on. But yeah, it's just so important to know that there are these two different tests. And now, if you haven't done antibody testing yet, make sure that you ask your doctor to order a cell-based assay. And if you received a negative result with ELISA testing, or you haven't been tested yet, it's always okay to ask your physician about the different types of tests that are available and which one he's ordering. It's okay to request a cell-based assay because you know that it's more effective at identifying those antibodies. Now, a spinal MRI can also help doctors distinguish between MS and NMOSD. And there's some characteristics that are different between MS and NMO. Inflammation of the spinal cord is a frequent first symptom of NMOSD. And we see that 60% of patients in one study have experienced symptoms related to spinal cord inflammation at the onset of NMOSD. I think in our scenario, in Sarah's path, she's experiencing optic neuritis as some of her first symptoms of NMO. This slide is really cool because it really is good at illustrating a point. Now, spinal cord inflammation also tends to look different in the two diseases. Now, first, let's talk about multiple sclerosis. We'll see that the inflamed area is often shorter and oval in shape. And this is the inflamed area, that sort of lighter gray portion. And we see that it extends across two vertebral segments. Now, when we contrast that with NMOSD, we see that the inflamed area is often longer and wider, and it tends to fill the width of the spinal cord. So if we are looking at this, we can see we've got 1, 2, 3, 4, 5, possibly 6 vertebral segments. Now, getting a spinal MRI in addition to a brain MRI early on, it can help facilitate that diagnosis of NMOSD. And I want to make a very, very important point here. I'm not a radiologist. These pictures are really, really good at illustrating a point, but I would not want anybody to think that they should be looking at their MRIs and trying to diagnose this themselves. The great part about this slide is that it gives you some information so that when you're looking at those MRIs with your physician, you can ask those informed questions. We're back to Sarah's path to diagnosis. We're at final part 3. And we see that Sarah has struggled to cope with the reduced vision in both of her eyes. Unfortunately, she has experienced a third attack. 3 months later from the last, she experiences now sharp, intense lower back pain and weakness in both of her legs. At the hospital, a spinal MRI shows extensive spinal cord damage consistent with NMOSD. And now anti-AQP4 antibodies are retested, this time using the cell-based assay, not ELISA. And this time the results have come back positive. So Sarah's finally diagnosed with anti-AQP4 antibody positive NMOSD. And so at this point, we see the positive in the diagnosis because now she and her physician can really work together to manage her condition because we have that understanding of what we're dealing with. something that we want you to really take away from this presentation is that if you're in a situation like Sarah's, be sure to talk to your doctor. Talk to your doctor about diagnosis. Ask if there's other possible diagnoses that have been ruled out. And if NMOSD hasn't been considered, you might ask your doctor about blood antibody testing. And then also ask about the types of tests. If you've already been tested, ask what type of antibody testing was ordered. If it was ELISA, it's okay to request a cell-based assay. The most important thing to learn, though, is that regular talks with your doctor can lead to potential modifications in your care plan and may help reduce the risk of additional attacks. It's so important that your physician has that full clinical picture of you in order to really make that most accurate diagnosis. And now I'm going to hand it back to Mike so he can wrap us up and bring us home.
Thanks, Bill. So let's just recap what we've discussed today. Though some symptoms of MS and NMOSD are shared, blindness, nausea, hiccups, and vomiting are only associated with NMOSD. Getting the right diagnosis matters because a misdiagnosis of MS may be potentially devastating, may have potentially devastating consequences, excuse me. Anti-AQP4 antibodies are frequently found in patients with NMOSD, but have not been found in patients with MS. If you aren't responding to your MS treatment, don't hesitate to ask your doctor to run a cell-based assay to test for anti-AQP4 antibodies. And now it's Q&A time.
Bill,
again,
can you hand the hostship over?
Yes, I'd be happy to. Okay.
And thank you all.
Yeah, that was excellent. Okay, I am going to, am I host now?
Not yet. Oh, there you are. Okay. Couldn't find you in my panel.
Oh,
Let's see, make host. There you go. I do.
thank you. Okay, I am going to stop the recording for compliance. Stop it.